Hi, afternoon. Thanks, Christina, for the kind introduction. So my name is Shin. I'm from Nursing Division at SGH. So primarily, my duties cover nursing quality research and transformation at SGH itself. Yeah, so without much further ado, I would like to go through the challenge statement in a bit more details. Really, our question is, how might we leverage on technology and big data to prioritize care for patients based on clinical need and urgency? Very much what we want to do is really moving from a list-based kind of care to a risk-based kind of care and prioritizing care for patients based on clinical need and urgency as well. We want to be able to risk stratify our group of patients so that we can give the appropriate level of care and to give the appropriate level of care as fast as possible as well. Next slide, please. So the use case that we have in mind is that for pressure injury. So for those of us, the non-clinicians among us, I will just give a little bit of explanation about what pressure injury about. It is a localized injury to the skin or the underlying tissue over a bony prominence. So you can imagine this can be at the heels, at the sacrum, elbow, and places like that as a result of pressure or pressure in combination with shear and or friction. And there are various both extrinsic and intrinsic factors that impact on whether or not patient develop this condition. Next slide, please. So as with various other conditions in healthcare, very much risk assessment is the first step to pressure injury prevention as well. Only after we assess the pressure injury risk, we will then be able to inform the next step in terms of implementation of an individualized management plan to mitigate against these modifier risk factors. And honestly, these are not my words. This is actually from international guidelines and recognized and practiced around the world as well. So around the world, everyone recognized that the way to benefit all stakeholders in this is really to prioritize interventions for those patients who are most at risk. So today, very much we adopt a very traditional risk assessment approach. Again, this is common across various conditions, whereby we just simply combine the patient score based on a variety of criteria, and these are evidence-based criteria, and we derive at a score of what this patient is in terms of high risk, low risk. But what we can achieve today, for example, at least in SGH, is that our nurses will do this risk assessment once a day for general ward or once a shift in ICU, every time the patient condition change and upon transfer as well. So we also have other tools whereby we try to help the nurses after they have risk stratify the patient into high or low risk, what are the appropriate interventions that they can take. Then from the prevention, and of course, we will see whether it leads to a good outcome or a bad outcome. So in this traditional approach, you can see that we are challenged by various issues in every step. So for example, when is the assessment done? Could we do it fast enough? Could we do it frequently enough? How accurate it is? And whether or not the assessment data is then being communicated down and we are able to inform the nurses in real time, and as well as how effective the prevention interventions are. So very much from a diagram perspective, from a 2D diagram, it looks like it's linear, but to be frank, on the ground, it's definitely not a linear relationship. So for example, coming to the part about when is the assessment done, as I mentioned, we're only able to cope with doing it once a day or once a shift, change in condition and upon transfer. But we look forward to a future whereby whether or not we can do a just-in-time assessment. So for example, at the day of admission, we have various features, and whether we can have this vector features being mapped out across different time window and combine them to a general feature vector to inform care. So the next challenge I want to really talk about is about accuracy. As I mentioned just now, the traditional approach in risk stratification is very much just scoring the patient on a set of criteria and then come up with a score. As you can see on the right-hand side of the slide, these assessment tools are known not to be very accurate. For example, this is the list of the AUROC, so meaning how accurate they are in predicting pressure ulcer. You can see the range really varies a lot. And on the left, you can see a recent paper that my team has published, that we realized that beyond just the traditional risk assessment score, we do have unique group of patients who need for us to incorporate other risk factors as well. So for example, is surgical patients, they're undergoing surgery. So we not only need to include other risk factors, but we also need to reflect changes in health status and treatment, which in the acute care setting can really happen very fast. So really the question we wanted to ask and really hope to achieve is that whether we can tap on the potential of machine learning as compared to human-led approaches. So in terms of the next so-called challenge that we face in the whole process, is about how fast can we communicate this risk to our healthcare providers so that they can take action. So again, this is another study that we recently published as well, looking into all the pressure injuries that's occur over the years. And I just bring your attention to the box in red. Basically, it shows that if we can shorten the time between the patient being seen, the patient being admitted and being seen by a wound care nurse, we would lead to better outcome. So the speed at which we do that assessment and being able to communicate that risk in real time to clinician does make a real impact. So this is actually what we have real time in the hospital now. But you can see this is actually a result dashboard. We show us in real time across the different wards who are the patients who suffer from a pressure injury. So we very much want to move away from the results dashboard to even having a risk dashboard so that we can action and even preventing the pressure injury from happening in the first place. So this is my last slide. So really what we want to achieve in this project is to be able to improve on our risk stratification methods and prioritize care and ultimately to reduce the burden of documentation, improve clinical workflows, and benefit all the stakeholders. Yeah, thank you.
Thank you. So now we would open the floor for a Q&A section for about 10 minutes. And we have a few questions that we received from our interested innovators earlier. So are there already defined different levels of clinical need and urgency?
Yes, there are. As I mentioned, the traditional way very much is based on just a set of criterias, and then we score the patient based on that. But increasingly, the literature point us to that beyond all these standard risk factors, there are many more out there, which honestly for a clinician on the ground at real time to look at all the other different risk factors before finally reaching a conclusion of how at risk this patient is very difficult. So for a human to do that and to pull out different data from different parts of the EMR, it is challenging. So that's how we hope that perhaps one day with machine learning, we will be able to do that at a very efficient basis.
Okay, understand. And sorry, give me a second. And does this solution that you're looking at have to be from a start to end user journey solution? So for instance, we are looking at when the patients first enter the clinic to follow-ups until it's determined that the patient would not need to return.
So
What's
what we
the
are
extent?
looking, yeah, thanks for that. So what we are looking at is not so much in the clinic, but we are looking at from the day of admission to the day of discharge. As I mentioned, because of the various treatment and procedures that the patient received during their admission, risk can really change by the day and sometimes by the hour. So to give an example, let's say when the patient is admitted, this patient is actually independent, walking around. This patient will be at low risk of developing pressure ulcer. But let's say the next day the patient go for a major operation. It's a very lengthy one. The patient is on sedative for the next few days. Then immediately the patient risk actually goes to high. So we want to be able to inform clinicians in as quick as possible that the patient's risk has now turned to high so that preventive interventions can then be pushed in as soon as possible.
Understand. So there was a question about the current use for risk assessment. So so Stella, thanks you firstly for the comprehensive presentation. And which kind of software are you currently using for risk assessment? So day
Uh,
of assessment and post-operation day.
Yeah, so it's not really a software per se, but we have it inbuilt in our EMR. So it's in a way it's like a standard checklist, like asking the nurses, okay, for this criteria, what do the patients score? For that criteria, what do the patients score? So it's not so much a software per se, but I would say it's more like a standard checklist or a standard assessment tool that we use today. Yeah.
So for the EMR, then does this analytics engine have to be integrated to that?
Personally, I think it depends, and we could take it in phases as well. I suppose during the first building of the predictive algorithm, we can do it outside of the EMR. But of course, with any system, we hope that one day it can be used at the point of care as well. But I'm not a IT person, but in my layman understanding, I suppose we can have the machine or the algorithm built out of the EMR, but the result being API back to the EMR itself to inform care.
Thank you. Also, there were other questions about the scope and areas of interest for this predictive analytics. Like, apart from pressure injuries, are you also looking for this system to handle other risks? Can you give examples?
Yeah, we are honestly, we are just starting with one use case, but you can imagine this is knowledge and learning that can be in a way applied to any assessment that we do that requires some prediction and some risk stratification. Another example will be the risk of a patient falling. Other example, the risk of patient developing delirium. So there are many, in a way, many assessments that nurses do day in, day out today. But whether or not that's the best risk tool, I think only when we start to study the data and putting in machine learning, that only we will know whether we can further improve the risk stratification, which personally I think we could, because there's only so much the human can decipher in real time from different parts of the EMR. But I believe that the machine can help us to do that.
Understand. Thank you so much. I think we don't have further questions so far from our audience, but I'm pretty sure more will come up later as we hear on the next presentation. So now we'll proceed to the next enterprise track, our challenge statement, which is on skincare diagnosis. So the challenge statement is, how might we better enable primary care physicians to instantly assess and analyze clinical dermatoscopic images to assist with the diagnosis